Welcome to Public Health Ideas. I'm Sandro Galea. I serve as Dean of School of Public Health at Washington University. Today I have the privilege of speaking with Professor Samuel Kizito. Dr. Kizito is a research assistant professor at the Washington University Brown School of Social Work. We're going to be discussing his recent paper in Social Science and Medicine. The paper is called The Long-Term Impact of Family Economic Empowerment on Viral Suppression and Mental Health Among Adolescents Living with HIV in Low-Income Settings, a cluster-randomized control trial in Southern Uganda. Professor Kizito, talk a little bit about where the study came from. How did it start?
Thank you so much. So I'll begin by giving you a bigger picture of HIV, especially in adolescents in Uganda. You find that compared to other age groups, adolescents have poor treatment outcomes, whereby we see that 1 in 4 adolescents will have poor adherence to HIV medication. And for that reason, another 1 in 4 adolescents will experience virologic failure. And we know very well that if we are to at least achieve control for HIV, we have to ensure that those who have HIV have suppressed viral loads, such that unsuppressed is equal to transmissible, suppressed is equal to untransmissible. For that reason, we sought to find innovative ways of making sure that those with HIV can suppress the virus. And we know very well that there have been several biomedical ways for ensuring adherence, but also viral suppression. But most of these have been based on the notion blaming the participant per se as the reason for not adhering. But we know very well there are reasons beyond the participant or the patient as to why they don't adhere to their medication. One of those is poverty. However much I would want to adhere to my medication, there are several reasons around poverty why I will not do so. And this is what motivated us to do this study.
Tell us about adolescents in particular. Tell us about mental and physical health of adolescents living with HIV in Uganda and the particular barriers that they face.
Thank you for that question. Adolescents, compared to other age groups, have a confluence of challenges, especially those with HIV. And yes, indeed, mental health is one of those. And to give some statistics, recent studies show that between 25 to 40% of adolescents with HIV also have comorbid mental health problems, the commonest of which is depression. And we know very well that it has a back and forth relationship, that HIV itself has pathways that can lead to depression, but we also know that those who are depressed can also engage in activities that can lead one to get HIV. So there is this mutual relationship, which unfortunately makes the situation very worse, especially in adolescents, a group that is very curious, even when it comes to engaging in sexual activities. So yes, mental health problems are a big burden in adolescents with HIV, commonest of which is depression.
So that actually anticipates my next question. Can you just elaborate a bit on the link between poverty, poor mental health, and retroviral adherence among adolescents?
Yes, so this is something we actually commonly see, that the two that I've already elaborated about, the HIV and the mental health, they link with each other. The third factor I didn't bring in yet was poverty. And these three form a devastating relationship. Those who experience poverty are more likely to have HIV. That has already been documented. But HIV itself, because of the costs associated with care, the loss of productivity due to being sick, leads to poverty. But these two combined together are associated with increased mental health problems. So the three united together, we find that it's a common co-occurrence for people with HIV, including adolescents. So this is a picture we have been able to demonstrate in a lot of our previous work, that when you address one and not necessarily address the others, you're not doing a holistic job in improving the well-being of this adolescent with HIV. And this has been part of the reason that inspired us to do work that addresses them as a whole. Address HIV, mental health, but as well as poverty, if you are to see a wholesome picture of improvement in the outcomes.
So let's talk about then what you actually did. So this was an intervention. So what was the intervention at the heart of the study? What did it consist of? And what emerged from the intervention?
Having realized the importance of these three factors, we innovatively implemented an intervention that had three main components. This was an economic empowerment intervention that had the first component involving opening up youth savings accounts, and these were savings accounts in banking institutions. And this has some advantages because it introduces these adolescents and their families into formal saving. Many of the communities in our societies don't get a chance to involve themselves in formal saving. So we could open up a bank account for the participant, give in an initial deposit of about $10, and then we encourage the family to save on a monthly basis. We could come and see how much they have saved. And then we could match it 1-to-1. If you save $5, we give you an additional $5. And we did this for a period of 2 years. But we also realized that it doesn't help much to only encourage you to save when you don't know what to use the money for or how to sustain it. So in addition to opening these bank accounts, we also gave them financial literacy training to help them on how to manage these funds, but also how to start up small businesses to sustain a long-term source of income. And this was beneficial to the adolescents themselves, but also their households as a whole. So this was our innovative combination intervention.
It is a really interesting intervention. So you have match savings account, financial literacy training, micro-enterprise workshops. I understand they all work together, but did one of these stand out from the others in any particular way?
I would have loved to answer that question now, but in our particular study here, I treated these interventions as a whole. So what I know so far is that the intervention actually works, but there is clearly a need to disassemble the interventions to see which one has a better impact compared to the other. And indeed, this is one of the future directions for our work. But for now, what I can tell you is we know the intervention actually has some impact as a whole.
Tell us a little bit, just two more questions to generalize a little bit about economic stability as a concept and as a construct. What role does economic stability play in ensuring that adolescents, just focus on adolescents, get access to antiretroviral treatment?
When we look at the main reasons why adolescents actually don't adhere to their medications, and part of this I'll tell you as a clinician who had to sit in the treatment room and I treated adolescents for almost a decade. Many times when they come to for their medical visits, many times you write the medication, you assess them, but then you tell them, okay, you can go and have this medication with food. Many of these people can't afford even a single meal. And once you take the medication on empty stomach, side effects are exaggerated. They realize that, so the next thing, they forego their food. So poverty comes in many forms. Food insecurity, which eventually affects adherence. But many of them, the facilities are 10 miles away. If you can't come for your medication, there is no way you can adhere to it. So if you can address these issues about transport, issues about food security, but also many of them have to debate whether to go and attend their job, even the adolescents, many of them work, versus going to the facility to pick their medication. They know if I miss a day, I may not find my job tomorrow. So they have to prioritize sources of income over adhering to their medications. So these and many factors around poverty eventually lead into poor adherence, which is the main driver of poor viral suppression. So if we can address poverty, we take away many barriers associated with finances, that eventually lead to poor viral suppression.
So I guess my last question builds nicely on that, which is how do we generalize these insights about economic empowerment interventions in Africa and globally?
So from our work, one thing we see is that yes, poverty is a major driver. And one thing I didn't mention about our result is when we looked at those who actually had very few resources, our intervention worked more on them, which basically drives us back to poverty is a major driver in poor outcomes in adolescents. One key message I can give is now to the policymakers and implementers to think also about ways of how to incorporate components that can address poverty in these programs that are targeting to improve outcomes for adolescents and HIV populations as a whole. Because many times they focus mainly on the clinical aspects, and we tend to forget these economic and other social drivers of health.
Last question. So what's next for your work building on this?
I have quite a number of directions where I want to drive this work. I still want to examine the exact pathways through which this intervention achieved the good treatment outcomes. I want to say, are there intermediate factors which can be targets for future interventions? That is one direction I really want to take. Another one is I want to disassemble and see which component of the intervention actually has a bigger impact compared to the other. And this actually work is already being led by our colleagues. And then one other step I would want to see is this work being scaled up, the intervention being scaled up on a larger scale so that it can be taken up to benefit even other adolescents who are not part of the study.
Well, I look forward to reading that work. Thank you for the good work you do.
Thank you so much.
And thank you for joining the conversation.